Hello, everyone. Apologies that this review session is pre-recorded and not live, but I think that I have a good chunk of what people had difficulty with on the exam written down, and we're going to go off that. The lighting is also a little harsh, I apologize, but there shouldn't be any glare on the chalkboard this time. Instead, the light is just pointing directly in my eye. So, three topics covered on this exam, just to do a quick overview of how the exam went, looking at it from the overall perspective. Pharmacology, shock, and resuscitation. Pharmacology, the class performed extremely well overall. We didn't have We had one pharmacology question in the top 10 most missed answers. So overall, it went pretty well. I have a few things that I'm going to talk about. None of them are straight up just doing drug cards like we did the one in the previous, in the exam 3, the pre-exam review session. We're not going to do any of those. I think, for one thing, those benefit you most when you make them yourself because you get a little bit of that tactile memory from writing the stuff down. But also, it takes up a lot of time for something that it seemed like people did very well on the exam. So I just have a few topics from pharmacology. Shock and resuscitation both had a pretty even split of more missed questions. We're going to talk a little bit more about shock because resuscitation, I really think that most of the answers are there in the book, and the missed questions we had were mostly about airway obstruction. So we're going to talk about airway obstruction when we get to that, but I'm not going to delve too much into the algorithms for resuscitation because they're laid out pretty clearly in the textbook, and I don't want to make this video too long. It should be broken up with chapters if you're watching it on YouTube or through YouTube. I'll post the YouTube link in the classroom. So if you hover your mouse down, in this general area, you should see there'll be little breakpoints and each section will be labeled. And if you go down in the description, there's a place where you can click on the chapter name and it'll jump right to that. So if you're feeling perfectly fine on pharmacology and you want to skip some of these things that I'm going to go over and jump to shock because that was what you had a harder time with, I would suggest jumping to that and then coming back to this if you feel like it's necessary. So to start with pharmacology, I want to just talk a little bit about agonists and antagonists. So we really only very briefly mentioned this subject in class, but I want to take a little bit of time to break down. This is a little bit deeper of a pharmacology topic, but I think that an understanding of this really helps, open up later things. So we'll use an example for each, but this is just generally how agonists and antagonists work with any medication. So the example I want to use for agonists, we'll do this one first, is albuterol. So albuterol its drug classification is a beta 2 agonist. And we know that we use albuterol for people that are having wheezing because albuterol helps to take the constricted bronchioles and open them up. How that actually works is, let's draw a little bronchiole. There's our little bronchiole. We put the one little split in it. On this bronchiole, there are strips of smooth muscle that can pull it tight or closed or let it open up. Now, when we inhale albuterol with a nebulizer, the little albuterol medication comes down into the bronchioles. It hits the walls eventually, and it goes into this smooth muscle. It just sits on the wall, and then just like when we give Narcan, it soaks through the mucous membrane. That's effectively what's happening here. The medication particles find their way into the smooth muscle. Now, what makes this an agonist is inside the smooth muscle, there are receptors, and we call them beta 2 receptors. So this would be a beta 2 receptor. Albuterol is an agonist, which means albuterol is a medication that we developed synthetically. We made it up, but we made it to be about this shape. Because when one of these beta 2 receptors gets stimulated, it tells the smooth muscle to relax, and that allows the bronchioles to open back up again. So how this agonist relationship works is this guy comes and plants itself in here, and activates this receptor to tell the smooth muscle to open itself up. That's that agonist relationship. Any of our medications that are agonists, the whole goal is for them to go unlock a certain receptor by being the right shape to fit into it, and then that receptor is what does what we actually want to happen. So albuterol comes in, it's the key for this lock, and once we insert it in here, that beta 2 receptor tells the bronchioles that it's time to open up. It relaxes that smooth muscle, and the bronchioles open up and allow more air passage. I forgot to get something to wipe the board off with. Stand by. So when we have agonists, their job is to come in and activate this receptor. So the agonist comes in, it tells beta 2, I want you to do your job, and beta 2 relaxes the smooth muscle and opens them up. Now we want to talk about antagonists, which are a little bit of a, weirder relationship. One of the antagonists that we as EMTs give is naloxone. That's an opioid antagonist. So our opioid receptors are all throughout the body. So I'm not going to draw a little picture like I did with a bronchiole, but opioid receptors are all throughout the body. And let's give it a slightly different shape from the albuterol receptor. Shapes are hard. There we go. So this is an opioid receptor. We usually call these mu receptors. That is the Greek letter mu. I don't know who came up with that. Somebody did. So we could have something come into this receptor. That looks weird. But say that this is morphine. Morphine's job is to come and attach itself to this receptor the same way that albuterol did, and it says to this receptor, hey, it's time to depress the central nervous system and eliminate that pain throughout the body. What we do as EMTs, what we give isn't morphine, but if someone has, say, taken too much morphine, then we might give trying to make it a little bit of a different shape. We might give this, which would be naloxone. Now, the way that these antagonist medications work is we want to give them a ton of naloxone. Now, I don't mean literally give them a lot of the medication as we dispense it. We're going to give the appropriate dose of naloxone per our protocols, but the number of actual naloxone molecules in there is millions and millions. So this naloxone is going to come into this receptor, but the thing is, it doesn't tell this opioid receptor to do that same thing. It's not telling the opioid receptor, hey, depress the central nervous system, eliminate pain, all that kind of stuff. Its job is just to be a key that can fit in this lock. So now morphine can't. Morphine can't get into this opioid receptor now. And when we give naloxone, we give a whole bunch of it. It fills up all these opioid receptors, all the morphine or fentanyl or codeine that's in the central circulation now isn't in any of the opioid receptors. The opioid effect wears off and our patients can wake back up. Their breathing comes back to normal is our main thing that we're looking for, but they may wake up, start getting at it, get angry, maybe, not usually if you dose it appropriately. But naloxone comes in and its job is just to hold the space. And that's why we call it an antagonist. Our agonists come in, attach to the receptor and tell it, receptor, I want you to do your thing. So morphine would be an agonist. It's coming to this opioid receptor and it's telling the opioid receptor, hey, depress the central nervous system to eliminate pain. Naloxone is an antagonist. It's coming to this receptor and it's just holding the spot in this receptor to stop something else from coming in. It's not activating this receptor. It's basically just like taking a key that you can get into the lock but doesn't unlock it and jamming it in there, and now the key can't pull out again, but you can't put a new key in there either because the keyhole's full. The keyhole has a key that doesn't unlock the door, but it also doesn't allow other keys to come and try and unlock the door. It's holding the space in this receptor so that an agonist like morphine can't come fill it. That's our agonist-antagonist relationship. Most of the medications that we give are either an agonist or an antagonist of some kind. We don't need to break every single one of them down, but obviously we just talked about albuterol is an agonist, naloxone is an antagonist. I think I mentioned this in class, but ketamine that we give at the ALS level, that's another antagonist. It goes in and blocks off receptors so that we can sedate patients and give them some pain relief at the same time. But I just wanted to briefly mention this relationship. I think the analogy that RJ gave in class about being a key that opens a lock is a good analogy when we think about this antagonist-receptor relationship with each other. But I wanted to get a little bit more into what makes an agonist different from an antagonist, because they both bind to a receptor, just one of them is a key opening a lock, and the other one is a key jamming the lock so that other keys can't come in and try and open it. That's all I really have to say about agonists and antagonists. It's not the most important thing that we're going to cover at this level, but I think that if you know what medications you have that are agonists and antagonists, it can help out a little bit with your overall understanding of pharmacology. The last thing that I'll sneak in here, naloxone is what we call a competitive antagonist. And what that means is naloxone is competing with morphine, fentanyl, whatever, to try and hold on to this receptor. Eventually, the naloxone that we've given will go away. And I mentioned this in class, if the naloxone we've given goes away before morphine or whatever has been metabolized and removed from the system, if there's still leftover opiate in the system, then once the naloxone goes away, morphine can still come fill this receptor as an agonist, and this can start doing all of its opioid stuff and once again depress our respiratory drive in a dangerous way. That's why, although, opiate overdose wake-up calls where we go, their respiratory drive is depressed, we give them naloxone, wait a few minutes, assist their ventilations, and then they wake up. When we have patients like that, when they want to sign off, we need to be extremely, extremely clear that this is still a possibility. If that Narcan wears off in your system and you still have opiate in your bloodstream waiting to attach to these receptors, you could re-overdose even though you've received the Narcan. It's very similar to how we can have repeat allergic reactions after we give epinephrine, because the epinephrine is just sort of a holdover until the body clears the allergen out of its system. Naloxone is a holdover, and we give it hoping that it will occupy these receptors long enough that whatever opiate that is dangerous that is in the system will clear out. We have another kind of antagonist called a non-competitive antagonist, but those get a little weird, and we're not going to worry too much about them. All right, the next thing I want to cover is routes of administration for meds. These fall into two general overarching categories, and those are the enteral routes of administration, and this is in your textbook, and the parenteral routes of administration. Enteral and parenteral. Now I have a list here on my phone because I don't want to forget any. But basically, our enteral routes of administration are ones that use the GI tract. So the main ones for these would be our oral meds. When we take a pill and we swallow it and it gets dissolved in our stomach acid and then the intestines absorb it and then it goes into our blood, that would be an enteral medication administration. The other ones that we have over here are sublingual. We give our nitroglycerin sublingual. We put it under the tongue. It dissolves in the saliva. So the saliva drains down. And, of course, the opposite of oral, our rectal medications. Now, we wouldn't think that as EMTs we give any rectal medications, but as EMTs we can assist some patients with their rectal medications. In particular, a medication called Diastat, which is diazepam in a rectal capsule. Diastat is often prescribed to children that have frequent seizures that are not yet under control with other medications. Most of our patients that have a known history of seizures keep their seizures relatively under control with daily use of anti-epileptic medications like Keppra, especially in our kids where maybe we haven't found that therapeutic range for Keppra for them, or their seizures are non-epileptic and we're still concerned that they're getting harmed by them. We haven't figured out how to keep them tamped down long term. They'll get prescribed Diastat, which is diazepam. It's a benzodiazepine that is wrapped in wax. You insert it into the rectum, the wax melts from the warmth of our body, and the diazepam gets absorbed. All right, and then on the other side, we have our parenteral routes of administration. For us as EMTs, our biggest parenteral route of administration is intramuscular injection. Can't spell. Intramuscular. Parenteral routes skip the GI tract. So when we give an IM medication, we have, say that's a muscle, and then we have arteries and veins that are traveling through that muscle, providing it with nutrients. When we inject an IM medication, stick a needle into the leg or the shoulder, we inject an IM medication, the medication just builds up in a little glob here inside the muscle. Slowly, and slowly is a relative term, faster than if we gave it orally, but not as quickly as if we gave it intravenously, this medication will absorb into the bloodstream and start to take effect. So there's no process of absorption through the GI tract like we see with our enteral medication administrations. Our other big parenteral medication administration that we don't use as EMTs, but the higher levels do, is intravenous. Our intravenous meds go directly into systemic circulation. For all of our medications, really, the goal is to get them into systemic circulation at some point. Not all of them, but for the majority of them, we're giving them by some route that will get it to the systemic circulation. Our sublingual meds, we're hoping will get absorbed into the bloodstream. Our IM meds, we're hoping will get absorbed into the bloodstream. When we give meds IV, we're putting them directly into the bloodstream. So we get the quickest effects from those meds right away. Sort of our partner to IV administration, where we get the effects right away, is IO administration, intraosseous. And that's when we drill into the bones and we get to the bone marrow at the center and we inject our meds through there because we know that we have veins and arteries that go directly into that bone marrow. So once again, we're putting it directly into the system. Apologies. Our intraosseous meds are close to the same thing as intravenous. At the ALS level, we can give pretty much every med that we can give IV, we can give IO. There are some meds that we know are better to be given by one method or another, but these two are both in the same ballpark where we get directly into the systemic circulation. The last one that I'll mention on here is subcutaneous. And that is sort of an in-between from topical, which we'll talk about in a second, and intramuscular. So we have the layers of our skin. So if this was the outer layer of our skin, and we have a little bit of fat underneath it, and then we have our muscle tissue like that, and obviously eventually we get to bone and that kind of thing. When we do IM injections, we're injecting into here, and there's just a little bit more blood vessel that goes through this area. When we give sub-Q injections, subcutaneous, we're injecting them into here, where there's just a little bit less vasculature, so it takes a little bit longer for them to get absorbed into the bloodstream. So usually when we give sub-Q meds, we give them that way purposefully because we want a slow absorption time. Our poster child for this would be insulin. We pretty rarely ever give insulin IV because it just acts too quickly, and we can very quickly send someone straight down the hill into a severe hypoglycemic emergency. So we give it sub-Q, and it slowly absorbs into the bloodstream, and little by little it brings our sugar down over time. A lot of our patients might take insulin once a day sub-Q. Some of them will take it a couple times a day after a meal, before a meal. They do calculations to determine how they want to give it. But that's our subcutaneous method of administration. It goes in between the skin and the muscle tissue that's down here, and it absorbs a little bit slower than putting the meds directly into the muscle tissue. Last couple honorable mentions in terms of routes of administration. We have topical medications. Topical meds we've all probably heard of. They go directly on the skin. We have thousands of different topical medications out there. Some of the ones that we see in EMS occasionally might be something like a fentanyl patch. A fentanyl patch, obviously topical is going to be one of our absolute slowest methods of administration. So a fentanyl patch, put a patch on your shoulder or on your back, and it releases slowly the fentanyl and gets absorbed into your bloodstream. So you just put that on, you can leave it for several hours at a time rather than taking a pill. Other topical meds, some of our, not that we can administer as EMTs, but some of our patients might have nitro paste. So the three ways that we usually see nitro are as the little sublingual tablets that we can give our patients. We also have the spray. As EMTs, we can assist with either of those. Nitro paste is above the scope of practice of an EMT. Nitro paste does the same thing as nitro, and it works in the same way as a fentanyl patch, basically. You measure it out. That's how we dose our nitro paste. You give it in a number of inches. So you do like 1 inch of nitro paste. It gets stuck usually on their chest, absorbed into the circulation, and then it has the same effects of normal nitro, just it lasts a longer time because it's a bigger dose that's being absorbed slowly rather than one of our little sublingual tablets, which we give. Its peak effect is very quick, but if the patient has continued chest pain, that chest pain is going to come back 10-15 minutes later at most. They just don't last super long. And then, we have other things we can throw up here as well. Nicotine patches, sunscreen, all of those are topical medications that our patients might have. We at the EMT level don't give any medications as topical. All right. Inhaled. Our big one for this is going to be O2. Oxygen is our most frequently given inhaled medication. Excuse me. And it's relatively simple. You inhale it, goes down into your lungs, and it gives you more oxygen. Sort of also in this category would be albuterol. You could make a whole separate category called nebulized medications, because the goal is a little bit different with nebulized medications, but we're still inhaling them. We give nebulized medications sometimes that do what we want to do, where they impact directly in the bronchi and the bronchioles. That's where we want albuterol to work. We also can give some medications outside the EMT level that we want to work all the way down in the alveoli, and we can give some nebulized medications that we want to work up here in the pharynx. So they can follow a different path. They're all inhaled, though. And then lastly, intranasal. Now, in our pharynx, let me draw another horrendous side view of a person. What do people look like? Trachea, jaw. We have the nose. Sure. This is our nose. This is our mouth. This right here, draw this a little bit more open. This back here is our nasopharynx. Now our nasopharynx has very thin cell walls that are very well vascularized, and that's why we can give medications directly through the nose. They hit this back of the nasopharynx and they absorb really well and get into our systemic circulation quickly. So for us as EMTs, our intranasal med is naloxone that we just talked about. There are a lot of other meds that we can give intranasally. We're finding more and more that we can give almost anything that we can give IM, we can give IN into the nose. But that's our last guy for routes of administration that we're going to go over is intranasal. Okay. Last thing that we're going to talk about in pharmacology, because there was a question on the exam A about it, but also just it's a topic that comes up a lot in general, is aspirin versus nitro in our patients that have chest pain. When do we give aspirin? When do we give nitro? When do we give both? When do we hold off on one? Etc., etc., etc. The big thing that this comes down to is nitro is an analgesic to us. Nitro is about pain management. Aspirin is an antiplatelet. Aspirin is about increasing survival. And that is really what this whole thing comes down to, is aspirin is there to give a better chance that these patients are going to survive, and nitro is there to make our patients more comfortable. So we know that we have indications, we have contraindications for both. For aspirin, any patient we have that has chest pain, generally presumed cardiac chest pain, but since there's so little we can do at the EMT level to definitively rule out cardiac involvement in our chest pain patients, we tend to go with aspirin for almost all of our chest pain patients. And we have a contraindication for aspirin if a patient has known bleeding somewhere. They say, oh, I have horrible stomach ulcers, something like that. That can be a contraindication for aspirin. On the nitro side of things, our indications are, one, that they need to have chest pain, just like with aspirin, but also that they need to have a prescription for nitroglycerin for us to be allowed to administer it. We can't pull the nitro out of the ALS bag and give it, so our other indication is that they have a pre-existing script for nitro. Our big contraindication for nitro is blood pressure systolic less than 120 millimeters of mercury. So we have those contraindications and indications for both, but I just want to talk a little bit more about what each of them does and why aspirin should be our priority over nitro. So here we have a coronary artery. This is one of our coronary arteries, which means this is one of the arteries that feeds the heart with blood. I'm not a good enough artist, so I won't try and draw the heart, but you can imagine that this is one of the arteries that runs down the surface of the heart. Like RJ mentioned during a previous class, these arteries have multiple layers to their walls. I'm just using random colors here. Obviously, this isn't what people actually look like on the inside. But we have multiple layers to these walls. And our patients sometimes will have too much cholesterol in their blood. And this is the most common instance from where we have a heart attack come from. There's other ways you can have a heart attack, but this is, our 90% of cases is from this. So these little yellow dots floating around are cholesterol, or just lipids in general. We might hear about our patients having hyperlipidemia or hypercholesteremia. Those are from high cholesterol levels in the blood. What these lipids will do if we have too many of them is they don't build up directly on the arterial wall, they build up inside the arterial wall. So these guys deposit and they build up in here between the first and second layer of the artery. Let me give myself a little bit of space here, get rid of these other lipids. As they build up more and more, they can actually create a bulge in the inner wall of the artery. And we call this atherosclerosis. This narrowing of the artery, we can see now that this distance is smaller than it used to be. I almost cut it in half. Theoretically, we can have patients that are that severe. This narrowing of the artery from the buildup of plaque inside the arterial wall is called atherosclerosis. Now, what happens eventually is this buildup becomes so large that we have a pop. Our artery goes pop on the inside because it can't hold down all this atherosclerotic plaque anymore. When that happens, now we have basically a hole on the inside of our artery. Now, we're not going to develop an aneurysm here like we talked about last class because this plaque is here. That's not something of concern. But we do want to heal this little hole that's developed. So what happens? Our platelets come to the rescue. Remember that platelets are sort of like little flat discs that can come, and what they're going to do is they're going to layer up on top of this break to plug the hole that was created. Now we'll notice that this plug has narrowed the artery even more. And there's still more platelets to come. So now that this plug, I'll just fill this in instead of leaving it all as the little lines. Now that this plug has narrowed the artery even more, now we're at the point where blood flow in this direction is barely happening. We're getting only little bits of blood are making it through. And our patients are going to start to have chest pain because whatever's down here isn't getting as much oxygen as it needs anymore. This area is going to start to develop ischemia and eventually infarct. So when we give aspirin, the goal is we give aspirin. Now, when these new platelets come in, let's say my piece of orange chalk is 1 platelet. This platelet that was going to come in and stick on here, now it, doink, bounces off. Or more accurately, it slides along, and it just keeps flowing down. It doesn't build up this platelet plug more, because eventually that would cause the artery to become restricted altogether. So when we give aspirin in chest pain, it is a life-saving medication. That's why we give it. Aspirin's not going to make this plug that is already in here any smaller. It can only stop it from getting bigger by making any new platelets that come slide along and continue down the track. That's why aspirin is our #1 priority. Not giving aspirin could result in this last little bit getting plugged off. Once this whole thing is plugged off and blood flow ceases altogether, giving the aspirin now isn't going to make this plug any smaller. And it's not going to, it would prevent it from getting bigger in theory, but we've already completely blocked it off. So the job is done. The only way that we're going to get this out of here now is either by giving medications that can break up this clot, which only the hospital can do, or by going to a hospital that has a cath lab, and they will go in and insert their little stent that will blow up this artery to give space for blood to flow again. But aspirin is our life-saving medication. That is why we give it. Nitro, on the other hand, say we're in the same situation. We had an atherosclerotic plaque. We popped a hole in it. We built up a platelet plug. And now our blood flow is reduced. Drawing very thin little arrows to show that we're not getting much blood flow. What nitro is going to do is just open up this artery a little bit more so that we can have more blood flow again. You can see we made a little bit more space. Now the artery's more open, blood can flow again. But the nitro is going to wear off. And this is going to come back to the way that it was. And we will once again have very minimal blood flow through this area. When we have the nitro given and it opens it up, then we're gonna have pain relief because oxygen is getting, a little bit more oxygen is getting down to this area again, and the cardiac tissue isn't dying as quickly. But when the nitro wears off, we're gonna close up again. And if we hadn't given the aspirin, this platelet plug will just keep getting larger and larger until, like I said before, it's blocked off the artery entirely. And once it's blocked off the artery entirely, nitro just isn't even as effective anymore. Opening this up more with nitro and allowing blood to flow again, we don't reperfuse with nitro. Once this complete blockage happens, a lot of our patients that we give nitro to don't even have any relief from it. They don't feel better anymore because this complete blockage has already happened. So aspirin is always going to be our number one because we want to focus on that life-saving first. And then nitro is going to come second as a pain management tool. I'm not saying pain management is bad or useless. If our patient's having a heart attack and their heart rate is already elevated and giving them pain management helps to regulate that, helps to regulate their tachycardia and their blood pressure, keep that stuff down, that will help the heart survive longer. But aspirin is still our number one. Nitro for pain management is better than no nitro, but not nearly as good as aspirin. All right. We're going to pause for a minute here. That's all we have for pharmacology. And we'll come back and do shock. All right. So I want to talk about shock next. Shock was definitely our lower scoring category on the exam. It's a hard topic because it's an easy thing to say, yes, they're in shock, but like I said in class, it's a hard thing to say they're in this type of shock, which means it's this mechanism happening, and et cetera, et cetera, et cetera. I'm going to focus mostly on distributive shock because it's our biggest overarching category, and it's definitely our most difficult to interpret category. But I want to start with some just background stuff. So first, we'll do stages of shock. Now, there is like literal defined stages, but I want to more just talk about our general progression with shock. So let's say we start to lose that ability to maintain volume. Now, when I say volume, I don't mean literally hypovolemic shock. We could be talking about distributive, whatever. We have a problem with one of our things. We don't have enough juice, our pump isn't strong enough, or our pipes aren't holding like they're supposed to, whatever situation. Usually, our early signs that we're going to see are mild tachypnea, remember, which we know means fast breathing. And when I say mild tachypnea, our early stages of shock, we are breathing a little quicker because our body's trying to increase the amount of oxygen that we're getting in. So our early stages of shock, this tachypnea is about O2. We want a little bit more oxygen than we're normally getting. Usually after that, we start to have a little bit of tachycardia. And this is our body trying to compensate by beating faster to maintain blood pressure. So we're trying to get our BP up a little bit. And the important thing is, in this piece of shock, we're succeeding. So we're going to see normal blood pressures, because the tachycardia is enough to keep our blood pressure up. Once we've gone through the little bit of extra breathing and now our heart rate is starting to increase, then we might start to see some of the external changes. So I'm just going to label those generally with one of our main ones being pallor and diaphoresis. So we might start to get a little bit pale, and we might start to get a little bit sweaty. Now, what our body's trying to do here is redirect flow. So we have started breathing a little bit quicker, trying to get more oxygen so that the blood that is circulating is a little bit more dense with oxygen. When we've run out of that as a compensating mechanism, we're going to increase our heart rate a little bit to maintain our blood pressure where it is. Well, now we've been able to maintain our blood pressure for a little bit, but we're starting to move past where that works. So our body starts to do the redirection of flow to our more important organs. And we start with our skin and our extremities. So we're redirecting flow to the core. Heart, lungs, brain, obviously are our big three. But in this earlier stage, we're also keeping blood in the stomach, the liver, the spleen, the intestines. We're keeping them in these core trunk things that really matter. And we're pulling a little bit from the extremities and from the skin, which is why we start to get a little bit of that paleness and a little bit of that sweating. When we've moved on, we're breathing a little fast, our heart rate has increased to maintain BP, we've started to redirect flow. When that has stopped working, then we might get a little bit of the GI distress. And this is the same thing as before. This is still a redirection of flow. Just now, we're redirecting flow not just away from our dermis, our skin, and from our extremities. We're redirecting flow from our less essential organ systems. So less flow to the intestines, less flow to the stomach, because they're, we need them for sure, but they're not as important as heart, lungs, brain. So we're sending as much flow as we can to the big three: heart, lungs, brain. And then really somewhere, and like I said in class, it's not the super clear area, but somewhere in this fuzzy area is where we decompensate. And now we start to see our later stages of shock, the hallmark one, of course, being hypotension. And this is just because all of these previous compensatory mechanisms are starting to give out. So we've been breathing faster, we're increasing our heart rate, we're redirecting flow from less important organ systems, and when all of that isn't enough anymore, then our blood pressure starts to drop. So this is usually our hallmark sign of decompensation, because all of these are compensatory mechanisms. Once we get down here, once we start to get hypotensive, then we're talking about, okay, if our blood pressure gets too low, we're not going to hit brain, heart, lungs anymore. We're not going to be even getting our big three. That's what that decompensation is. And then one of our later stages here as well is deep, rapid respiration. Or, as I would like you guys to start thinking of it, Kussmaul respiration. Remember, this is one of our abnormal respiratory patterns, like we talked about. Kussmaul, Kind-Stokes, Biot respirations. Kussmaul is the biggest one that I really want you to remember, and that's very deep, very rapid respirations. And that's because now we're at the point where lactic acid is building up. Remember, we talked about how when our bodies don't have enough oxygen to do aerobic metabolism, our preferred energy efficient kind of metabolism, our bodies will switch and they will do anaerobic metabolism. And anaerobic metabolism results in lactic acid. So up here, when we started sending less oxygen to our extremities and then eventually to our GI system, when we did that, those things aren't getting as much oxygen anymore. So some of those cells are going to start to do anaerobic metabolism and produce lactic acid. When we get down here to the hypotension phase, many organ systems are now producing lactic acid because nobody's getting enough oxygen, because nobody's getting enough blood flow. We're going to maintain heart, brain, lungs above everything else, but as our blood pressure goes down and down, there's only so much we can do to maintain them. Remember, we said in class that our brain needs a mean arterial pressure greater than 65 to perfuse itself. So if our blood pressure goes down, 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 then we're not going to have enough oxygen going to our brain anymore. These are the ways that I think about the stages of shock, and I made this note because these visibly look different in our patients. Our tachypnic patients early in shock usually are just trying to get that oxygen boost, and it's more like even if it's not quite that fast, they're closer to a normal depth and they're just a little bit quicker. Later here, when we get to the point where we're trying to breathe to get rid of acid, it's more like it's very deep and very rapid all at the same time. And if I can find the question, I'll point out exactly what I'm talking about. So, question 28 on your exam. See if I can hold this up well. When assessing a patient with signs and symptoms of shock, it's important to remember that right in here, the option A was the patient's respirations are deep during the early stages of shock. We might see some tachypnea, but when they say deep, they're referring to this all the way down here with hypotension, the late stage form of Kussmaul respirations, because we're trying to remove lactic acid from the body. There tend to be a lot of test questions when we're talking about shock where they really want you to have drilled in, just like in that question, that blood pressure changes are one of the last signs in shock. They really, really want you to have that nailed down. Let me see if I can find the picture here for the next thing. I have it pulled up. Where's the one that I just had? There we go. All right. Get you guys on the view with my screen. And we'll see here that in our adult patients, when we go into shock, we have this steady increase in heart rate to try and maintain compensation for the BP. But this compensation is happening relatively in progression with one another. We start to see some early blood pressure changes. Now, these aren't labeled because this is a conceptual graph. It's not meant to be like a literal demonstration. So over here, these BPs, even though they're going down, our goal map of 65 might be somewhere around here. So we're seeing some change in blood pressure, but as the heart rate's coming up, these initial blood pressure drops are not dangerous blood pressure drops. They're not just tanking right down to zero here. On the child side, we see that our blood pressure is maintained very consistently for a long time, while our heart rate spikes crazy high to maintain that blood pressure until all of a sudden there's just too much fluid loss or there's too much neurogenic issues going on, whatever our pathology is in that situation, and our blood pressure drops off very quickly. And we can see even here in our late stages of shock, our blood pressure starts to fall very quickly towards the end. When we are getting to these points, these are our real true decompensated shock patients, because you take a blood pressure and it's 70/40, and you might take a blood pressure 2 minutes later that's 50/30. Their compensation just gives out very quickly once we move beyond the point of compensation. So here with our children, we see a quick drop off after a very high level of compensation with heart rate, whereas with our adults, we're more smoothly moving in the direction of one another. Okay, I wanted to just touch on that quickly in terms of the adults versus pediatric patient progression of shock. It's a fundamental thing to know about the difference. When we teach pediatric education for the pre-hospital provider, which is a special course just on pediatrics, one of the things you're taught to look at very early is their breathing. Because in adults, we might see that quick breathing and that tachycardia both come on pretty quick together. But because the kids are so good at compensating, they might have an increased work of breathing very early and you not see some of those other changes until a little bit later. Work of breathing is one of our key things when we talk about treating kids. It's part of, we have a pediatric assessment triangle, and one of the sides of that triangle, the 3 biggest points to know with kids, is work of breathing, because it can be such a good indicator in our pediatric patients of their overall status. All right. Let's start with distributive shock, because I think it's the most important one to talk about. So distributive shock is our pipe problem. So we have an issue where for some reason the pipes aren't doing their job to maintain blood pressure. We have a lot of subtypes of this, which is why it's the one that we need to put the most work into. Septic shock is distributive. Neurogenic shock is distributive. Anaphylactic shock, as well as psychogenic, something we didn't cover too much in class, but is a type of shock that we can see from time to time. So let's go down the list here, and we're probably going to spend the most time on sepsis, because I think that it's one of the more difficult ones to understand, and it's one of the most important ones for us to understand, because septic shock is probably the kind of shock that we're going to see the most often. Neurogenic shock, usually associated with trauma, pretty rare. Anaphylactic shock, hopefully we don't have to see. That's one that we'll probably see from time to time, but not super often. Psychogenic shock, same thing. It's a time-to-time thing. And then cardiogenic shock, we usually only get into with those patients that have cardiac issues where we're way behind the 8 ball. Our heart attack patients and our pulmonary edema patients don't usually go into cardiogenic shock until it's been a while. So septic shock. Let's talk about sepsis in general. So sepsis is a body-wide infection. And how we develop sepsis usually is we have some other kind of infection. So pretty often a pneumonia or a UTI. And that infection gets into our blood. The bacteria from this infection enter the blood. So now inside this is a blood vessel. Inside this blood vessel, we've got these little bacteria that are floating around. Now, once the bacteria get into our blood, like I talked about in class, the lungs, great place for bacteria to live. Has all the things they need. It's dark, it's moist, there's a lot of oxygen. Talk about our blood being the best possible place that they want to live. It's generally super dark because it's inside a blood vessel. It's very moist. Our plasma is rich in proteins and nutrients, and there's lots of oxygen getting floated around if they're aerobic bacteria because it's being carried by our red blood cells for us to use. Now, what happens when we have these bacteria in the blood is they start to release toxins out into our blood. So these guys are now spitting out all these toxins, these little yellow toxins inside our blood. So we have bacteria that are releasing toxins. What the toxins do is they get in to these vessel walls where the muscles live that determine the size of that blood vessel. So that orange that's the muscular layer of our blood vessel that can make it smaller or bigger when it needs to. So these little toxins get into our vessel walls, and when they do that, this muscular layer starts to weaken, and our blood vessels dilate. So now this blood vessel is bigger, and that's really the core of our pipe problem. The blood vessels become bigger, it's difficult for us to constrict them again, and our blood pressure eventually starts to go down because we just don't have enough fluid volume to push hard against a bigger vessel. Now, the other piece of this, the piece that I think we had a harder time with as a class, because I understand what you guys are saying, it seems like that should be the case, this should be the case for hypovolemic shock, is those toxins that are in our blood start to make our capillary walls leaky. So remember, outside of this blood vessel, there's lots of cells of our body. That's why this blood vessel is here. It's bringing oxygen and nutrients to the cells. Now, because of that, our blood vessels are not like literal tubes that you can't escape from. We need to get very chemistry to get into the real depths of it, and very biology. But things need to be able to permeate in and out of these walls of the capillaries so we can get the nutrients and the oxygen that live in here to diffuse over to the cells. Now, one of the other things that moves around is our cells are full of plasma, which I've represented here as blue because plasma is mostly water. Water needs to be able to diffuse in and out of the capillaries to maintain the shape of the cells. Now, if we go back to our A and P chapter, our human cells are squishy. They're squishy little things. I don't really have anything squishy to use as a demonstrative. Our squishy little cells need to have both enough water in them to not get crunched down. If they don't have enough water inside, then the water outside will squish them. And they can't have too much water in them, or they get too big and then they pop. And then the cell dies, obviously. So water needs to be able to move back and forth across this membrane to keep the cells their right size. What happens in sepsis is these capillary walls start to become very leaky. They start to let too much water out. All this water now is leaving the cell. But most of these cells already have the right amount of water in them. All these cells already have as much water as they need. So when our capillaries become leaky, all this water goes and starts filling in the space between the cells. This is what we call third spacing. We want the majority of the fluid in our body to be either in the bloodstream or in the cells. Now, obviously, we have a little bit of fluid that lives outside the cells all the time because it's diffusing in and out of the cells and nutrients are being carried in and waste products are being sent back to the blood. But we start to get a lot of fluid between the cells. And we might start to see edema, which is exactly this process, fluid that's outside the cells and outside the vasculature causing swelling. We might start to see some of that process in sepsis because this happens. Now, I think the question that really comes up is, well, you're telling me the blood vessels are getting bigger, which I agree is distributive, but also that the fluid is leaving the vessels and we're losing volume, because that's what happens here. When all this fluid goes in and fills in the gaps between the cells, because the capillaries are so leaky, we start to lose volume overall. And you say to me, how is that not hypovolemic shock? Now, there's sort of two answers to this question. One, it kind of is a kind of hypovolemic shock. But at the same time, when we talk about hypovolemic shock, we talk about blood or fluid in general either leaving us completely or spilling out of our blood vessels, like when we're bleeding, and not osmosis, just being pulled out by capillary leakage. When we talk about hypovolemic shock, if it's a medical case, then usually that means we've either been vomiting too much or we've had too much diarrhea and the blood or the fluid is completely gone. Or in the traumatic case, if I get a cut on my arm, the blood is literally leaving me. I can't just put it back in. There is this sort of in-between one where we have internal trauma, but when we have hypovolemia from internal trauma, the blood is going through some kind of cut or explosion out of the vessel itself and spilling into all the empty extra space we have in our body. We can carry liters of blood in the abdomen, we can carry liters of blood in the thigh, all of these places that blood can leave the vasculature and pool in what's normally an empty space. In this case, nobody's literally cutting this blood vessel. The fluid is leaving and it's swelling up the tissues that are around it, by packing extra fluid in around all the cells. So if we look at just an example case, I'm going to erase this for right now, and we'll talk for a minute more about the general sepsis thing. But let's take the case of our liver. Our liver looks kind of something like this. It has big arteries that come into it, and it has big veins that leave it. When we have hypovolemic shock and we have a true just volume problem, it might be because we got something like a liver laceration. So we had some kind of cut here, and now blood is literally spilling out into our greater abdomen. Those are pants. That's this guy's legs. We also have in here, you know, a whole bunch of other organs in the background. There's a stomach here and a whole bunch of intestines that come off from it and swiggle all around, all crazy. And then we have a colon. That's like that. These are all small intestine. There's a lot that goes on in there. If we get this nick in our liver, this liver laceration, the blood is filling up all these extra spaces around the organs. That's the inside. That's our hypovolemia. All the blood is literally leaving. In this case, it's a traumatic sense. We're bleeding because somehow we got punched in the liver with something and it caused a laceration. But this is hypovolemia. In sepsis, what we would see is on a very microscopic level here, we have little capillaries that are surrounded by cells. In septic shock, what we're having is when these capillaries get, not the capillaries necessarily themselves, more the arteries and veins, but when these blood vessels get bigger, they're dilating from the sepsis. That's our distributive shock. And then when they become leaky, the fluid is leaving the blood vessels and it's just filling in this space between the cells. So all this space between the cells fills up. And what we would see is overall swelling of the liver. Because what used to be a relatively compact bunch of cells now is getting full of a lot of fluid that's normally inside our blood vessels. So I hope that makes a little bit of an explanation as to why this capillary leakage is different from hypovolemic shock. Yes, there is fluid leaving the blood vessels and the overall volume is going down, but it's a very different process from the other kinds of hypovolemic shock that we talk about, where we're vomiting or we're having diarrhea, or our traumatic cases where we're getting cut either inside or outside, and the fluid is more literally spilling out of us rather than just leaving the blood vessels and swelling the surrounding tissues. This is more our septic shock case. Okay, septic shock, done. Neurogenic shock. So neurogenic shock is an interesting case. But let's look at a person. So we have head, arms, legs. There we go. Now we know in the back of them here, they have a spine. Coming off the spine are all of our nerves. Some of these nerves exist to stimulate the musculature on blood cells that says contract. So let's say we have this nerve right here, comes all the way down here somewhere, and at some point it runs into a blood vessel, and its job is to tell this blood vessel to be a certain size. More electrical stimulation, the muscles contract more. Less electrical stimulation, the muscles don't contract as much. So what happens in our neurogenic shock patients is we have an injury, say right there, where obviously all these nerves originate within the spine and go up to the brain. So we have a chop in that spinal cord, and this nerve doesn't get signals anymore. Let's do another blow-up view. We have a blood vessel here, and it's got some musculature in its walls. And then this nerve here that comes to it and tells it, hey, squeeze your muscle harder, squeeze your muscle less. If this isn't getting signals anymore, then nothing's telling this how much to squeeze, and the musculature is just going to let go, and open up to be much bigger. Now, one of the things that is sort of helpful to know to give this some context is muscles really just pull. So when we have, body systems that can make movements in multiple different directions, it's because we have muscles pulling on both sides to determine the position. So when I do this, the muscles really here in my forearm are pulling, but when I open my hand back up, these muscles can't push. All they can do is relax, and the muscles on the top of my forearm start to pull. So if these guys relax and these guys pull, I can make movement in both directions. Now our blood vessels just have sort of continuous muscle fibers that go around like this. So their version of pulling is pull tighter, and then when they relax, they just want to get bigger. This tighter position is sort of a strained position for the muscles. The muscles need to be stimulated to make them want to get smaller, and if you stop stimulating them, they'll go back to their nice biggest muscle totally relaxed size. So here in neurogenic shock, these stop getting stimulated at all, so they open up. There's not, a two-directional mechanism here. There's not a, hey, get bigger, and hey, get smaller. It's more of a constrict, 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 relax, relax, constrict, constrict. And if we stop saying anything at all, they just relax. Now, obviously, that was an example where I showed one nerve fiber and one blood vessel. What would happen is we'd get a cut, somewhere across our spine where signals stopped getting sent, and everywhere that those nerve signals were feeding would all wicked dilate, and our blood pressure would go down. All right, call that good for neurogenic. Anaphylactic, I don't even know if I'm going to draw a picture for, because it's a very similar process to septic shock. It's just if that whole thing were sped up way, way, way faster. So we take in a toxin or an allergen in the case of anaphylaxis, and our body has a really, really rapid immune response to it, where the same thing as in sepsis happens. The vessels dilate, they become leaky. Just in this case, it's because of a histamine response and not because of a toxin being released by a bacteria. But that actual process is the same as sepsis, just very, very rapid. We have a huge amount of vasodilation really fast. The capillaries start to become leaky, which is why we get mouth swelling, face swelling, all that fluid that's third spacing out of the blood vessels. It's not in the cells and it's not in the vessels. It's filling up the interstitial spaces, and they all start to expand, and we get swelling around our mouth and our tongue swells. All those things come from that capillary leakage. We can also treat that. Epinephrine. Real quick. Okay, psychogenic shock. So psychogenic shock is, a similar process to neurogenic shock, where we have our little guy here. Legs. And now what's happened is we have our brain and our spinal cord, and we have our nerves coming down and then out to the rest of our body. We have all these nerves. They're all doing the same thing as we saw in the neurogenic shock picture. They're all, on some level, there's a nerve telling blood vessels, get bigger, get smaller, get bigger, get smaller. Except what happens here is our brain just starts to go real crazy, and all of these blood vessels, all of these nerves at once just stop telling blood vessels to constrict, because the signals are all going wild all over the place. So the nerves just stop telling the blood vessels to constrict. All of them open right up all throughout the body, a rapid, widespread vasodilation. A lot of times what happens is this guy goes from being this guy to being that guy, but lying down on the ground because he passed out. The thing is, when he passes out, this brain in here starts to chill. The brain realizes that whoa, that was a lot. Everything gets depressed really quickly by that rapid vasodilation. This guy passes out. His brain cools off a little bit, starts sending signals normally again, and our blood vessels relatively quickly tighten themselves back up. That's why we call this a rapid, temporary, body-wide vasodilation. It comes on very quickly because everything opens up really quickly. But once we conk out, or if we don't conk out, you know, we have to take a minute to sit down and catch our breath because all of a sudden our blood pressure just took a big drop. The brain starts to calm down a little bit. The nerve signals return to normal. Our blood vessels go back to whatever size they're supposed to be, and our blood pressure comes back to normal. All right, that's everything that I had put down to talk about in relation to distributive shock. Oh, I have one that I think is just an interesting case for discussion, and it's another good example of the stuff that we see in septic shock. I'm going to give a warning here to skip 20 or 30 seconds ahead if you do not like gory images or if you do not like burn patients. But I want to talk a little bit about burn shock. So what happens in burn shock is all of, a whole bunch of tissue gets burnt, and then the same thing as in sepsis, a bunch of toxin gets released from all of this burnt tissue into the systemic circulation, and it causes the same vasodilation, and it causes really severe third spacing. And that's usually what we call burn shock, is an inability to maintain blood pressure because the capillaries all over the body are just so leaky, and everything starts to swell very aggressively. Now, what we see sometimes in burn patients as a combination of all these things put together is they will have, prototypical example, a burnt chest or a burnt thorax in general. That top layer of skin now has lost its elasticity. It can't stretch and expand when we breathe the way that it normally would. Because of that, our breathing becomes more difficult. What worsens that is all the tissue underneath the burnt tissue is starting to swell because fluid is third spacing out of the vessels in the cells because the vessels are full of all this toxin from the burn. We perform a procedure for that, not we being paramedics. Some critical care paramedics can do this in the field, and it happens in burn centers pretty often. But we perform a procedure called an escharotomy, where we cut the outermost layer of the skin so that it can expand. I'm going to give that warning one more time to skip ahead if you don't like burn patients or a gory image like this. This is from an article, but it's still not the most pleasant to look at. This is an escharotomy patient. So you can see that his outermost layer of skin here is still intact, but it's separated from the other layers where we've cut along these borders. Now you can also see that given how big this gap is, before the burns, obviously these two parts of the skin were touching each other. And we can see all this swelling underneath the skin. That is all from that third spacing in burn shock. Those capillaries have leaked and they've started to swell the skin. And when we cut it, they had swelled the skin so much that they separated away from each other. All right, we'll go back to the camera view. I just wanted to provide that as a reference. It's a similar process to our septic shock. All right. I'm not going to talk about obstructive shock because the class seemed to have that down pretty well. Cardiogenic shock, I just want to talk about a couple things with the heart. And I'll expand a little bit more outside of what's covered on this exam because I think they're just good things to know. So let me get a reference image so I can even draw the heart. I'm not the best artist, if you guys haven't learned so far. So we have the apex of the heart down here, and then we have the top of it, and we have the inferior and the superior vena cava returning blood to the heart, and then we have our aorta where blood is leaving the heart. And then we won't worry, there's the pulmonary arteries and the pulmonary veins in here as well, but I don't want to draw in every single piece of the heart. And then we know we have we have 4 chambers to the heart. Left ventricle, right ventricle, left atrium, right atrium. And we can see the way this is laid out. So this is all of our blood returning from the body. And it's going to the right atrium because that's where our path starts. And it's going to go down from the right atrium to the right ventricle where it's going to get pumped out to the lungs. And then it's going to come back into the left atrium from the pulmonary vein. And the thing that we're missing here a little bit is that the aorta comes down into here, and that's how we pump it up and out. Okay, just going to get rid of this little extra piece of aorta. The 2 main things I want to talk about are preload and afterload. So, preload is our big one. Basically, our heart needs to have a certain amount of fluid coming into it because the right side of the heart likes to get stretched before it pumps. It likes to feel, a good amount of blood pushing it open, and then it'll squeeze really hard, and it'll, through my chalk, push blood out to the lungs. The amount of pressure we have built up at that highest point before we squeeze and pump the blood, that is our preload. Our preload needs to remain high enough that we stimulate the right side of the heart to beat hard, to squeeze hard. Give me 1 minute, guys. Sorry. Apologies. That was a student reaching out to me. So our preload is the amount of stretch, the force at the peak of that stretch before we squeeze. The reason that's important is because the muscle cells inside the right side of the heart squeeze harder when we stretch them more. Like I said, they want to get pushed to their limits so they can really get a lot of blood out with just one squeeze. So our preload is dependent on how much blood we have returning to the heart. Our afterload, let me write these down so I at least have my terms laid out. Our preload is about how much blood we have returning to the heart. Our afterload is how much force we have to exert to push that blood along. So if we think about some different types of shock, when we have like septic shock, where we're losing volume, we have too much space beyond the heart, our afterload is going to be low. It's going to be really easy to squeeze that blood to the next place it needs to go because the pipes over there are way bigger than they're supposed to be. Our afterload in other cases, like with cardiogenic shock, because we have too much fluid, our afterload is super high because we're trying to push blood out maybe to the lungs, and there's so much fluid in the vasculature of the lungs where it's already seeping into the alveoli that the heart is working super, super hard to try and push that fluid really, really hard to get it to the other side of the heart, and the other side of the heart isn't picking it up fast enough, so it backs up into the alveoli. That's when we have a really high afterload. Low afterload, it's way too easy to push the blood. High afterload, our heart is overworking itself trying to push the blood. So we need to have both of those, preload and afterload. Not too much or too little of either. We need to have our nice little balance in the middle. All right. Cardiac shock, hypovolemic shock. Okay. Hypovolemic shock, pretty hypovolemic. It is pretty late, just like I told you guys I'd be making this video pretty late on Saturday night. So hypovolemic shock. We have two cases where we usually see this. One of them is purely medical, and the other one is trauma. Our medical cases of hypovolemic shock generally, not exclusively, but generally are slower progressions of hypovolemic shock. So under our medical causes of hypovolemic shock, we have the things we already mentioned earlier: vomiting, diarrhea. Other things under our medical, because one of the things to keep in mind here is that we don't lose red blood cells. This is fluid only. We're going to vomit out some bile with proteins in it and stuff like that, but we're not losing RBCs. We're not losing the stuff that carries the oxygen. But also under our medical side is a lot of our GI bleeds. So when we have a person, and we'll talk more about these when we get to GU-GI in a few weeks, but when we have, or next week maybe, when we have people that have GI bleeds, usually they're, obviously somewhere in the gastrointestinal tract, and then we can narrow down with some of our tools exactly where it's coming from. So if our person is throwing up coffee grounds emesis, that's one of our hot button terms, vomit that looks like it has coffee grounds in it, usually that's blood that was bled somewhere in the esophagus or in the stomach, usually the esophagus, and drips down into the stomach, mixes up with the acid and stuff, irritates the stomach, and then we vomit it out, and it has that coffee grounds appearance. On the other side of things, when we have blood come out in our bowel movements, if it's bright red, usually it's very late in the GI tract, because it didn't have any time to get all messed up with stomach acid and all that kind of stuff. A lot of our, frank red blood people, bright red blood, are either very late in the GI tract or they're an internal hemorrhoid, and it's bleeding right there at the exit from the GI tract. But our GI bleeds tend to be not always slow, but on the slower side than some of the stuff that we'll see in trauma. Our GI bleeds are going to leak out, but because we might not have obvious external signs that we're bleeding, if we're not, checking our stool or having gastrointestinal distress, they can go for a while before we know that there's anything going on. But these are, as is in the name, GI bleeds, which means there's blood loss. We're losing red blood cells with these, and we need those red blood cells to carry oxygen. These vomiting and diarrhea patients, we can treat relatively well with the fluids that we give in EMS. We can give them saline, we can give them lactated ringers, we can give them intravenous fluids, and it can be pretty beneficial for them pretty quickly. Patients that have these GI bleeds that go for a while before we notice, they might need blood transfusions because they need blood to replace the blood that they lost. All right, that's what I want to talk about for that medical side of hypovolemic shock. On the trauma side, we have the obvious thing. Bleeding. The traumatic hypovolemic shock we're talking about is half the time, not literally half the time, but in one case, very presenting of itself because we have external bleeding. So as long as we're doing our appropriate head-to-toe assessment on the trauma patients, we'll find that external bleeding. Now, we have obviously another category here. Internal versus that external bleeding. So external bleeding, we have a lot of good ways that we control it now. You know, for our extremity injuries, we have tourniquets, we have junctional tourniquets, we have wound packing, we have pressure. When it comes to like open lacerations to the abdomen, you know, we can at least try some of those pressure routes. There are things we can do to try and slow the bleeding down pre-hospitally. Our internal bleeding patients are a different story. We have all these places, like I said earlier in this review, that we can store blood that we leak out of ourselves. And when they're inside, we don't have a way pre-hospitally to treat it. And the hospitals only have a way to treat it if they're the right kind of hospital. So we had a question on the last exam that related to internal bleeding. It was something along the lines of you have a patient who appears to be bleeding into her abdomen, et cetera, et cetera, et cetera, and which of the following is going to make the greatest difference in her chance for survival? When we have these internal bleeding patients, what they need is both blood, which we don't have in this area in EMS, and they need that internal bleeding to stop. Now, in terms of EMS, there's not really any EMS where we can completely stop internal bleeding. But even in terms of hospital care, if I bring a patient to Claxton Hepburn and they have internal bleeding, Claxton doesn't have very much that they can do to stop that in the way that it needs to be stopped. They need to go to a trauma center where there is a surgeon there waiting for them to go inside and clamp off what's bleeding, put back together what was torn apart, and then transfuse the new blood into them so that we can replace what was lost with now the tank sealed up again. So, bleeding, internal versus external. I wanted to just talk briefly about that one question on the exam. That patient who's bleeding into her abdomen or into her whatever it was on the question, what she needs more than anything is to go somewhere where they can stop that bleeding, which would most often be a trauma center. We're going to do everything we can for her in the field. You know, we can do good monitoring, we can do Trendelenburg position, our ALS providers can give isotonic fluid, but we don't have blood in New York. So what she needs, what's going to keep her alive, is getting to a trauma center. All right. Talked about all my stuff I want to talk about for shock. Okay. Resuscitation. I don't have a whole lot to go over with this. It's more just going to be a couple brief talking points. Always look in questions about choking, what kind of choking they're having, if it's partial or complete, or as your book refers to it, mild or severe. When we have patients that only have partial airway obstructions, we don't start doing Heimlich, we don't start doing back slaps, all these things. We encourage them to cough and we transport them. If we can't get it up through that coughing, obviously, and if it doesn't turn into a complete airway obstruction. Our complete airway obstructions, we have a whole different ballgame. We do the abdominal thrusts, we do the back slaps. Eventually, if they go unconscious, we lay them down. We do just like our normal CPR algorithm, 30 compressions, look in the mouth. If there's something there, take it out. If there's not, don't go in. So keep in mind, like I said in class, that choking is considered part of resuscitation because there's so many pieces of it that line up together. So mild versus severe airway obstructions and the algorithms for each of them are really the main things to focus on there. I will say your book had said transport and apply, or your test had said transport and apply oxygen. I make my, instruction on oxygen very clear. We oxygenate as necessary. So if they had a partial airway obstruction and it was causing them to be hypoxic, we'd give them oxygen. If it wasn't, I probably wouldn't. The call first, care first rule, I think I ended up covering this relatively well in class. When we have kids that have a sudden onset of cardiac arrest, we give 2 minutes of care, and if their condition hasn't improved, we call 911. Or if their condition hasn't come back to completely alive, we go call 911 after 2 minutes of care. With adults, we call 911 as soon as we know they're in cardiac arrest, and then we start providing care. Or we 911 speakerphone, put the phone down, and go to doing our compressions and everything. But with kids, if the phone's if the phone's not right there next to you, if you need to run to the, the office next door where they have a landline, and you need to decide whether or not to do that or to start care, on our pediatric patients, we start with 2 minutes of CPR, and then we go get the landline and say, hey, I have a kid, CPR, 2 minutes of CPR so far, and he hasn't gotten any better. And then the only other thing I had on here for resuscitation was obvious signs of death. And we can talk about a few of them, but go look in your book or in the New York State protocol, and there are very clearly listed out signs for obvious signs of death. Our biggest one usually is rigor mortis, the stiffening of the body because the muscles are all tightening up following the death. Rigor mortis is one of our biggest ones. If that's onsetting, then it's too late to have a difference in care. Dependent lividity. A couple people had asked about that. Lividity is that pooling of blood that we can see in our patients that have died. If they're laying flat on their back, we'll have blood in their back and usually in their buttocks and their legs. The reason we use the term dependent there is because how the patient is positioned when they die will articulate where that blood ends up pooling. It's going to pool in the direction of gravity. So if they die sitting in a recliner, then they might have lividity on their buttocks and the bottom of their thighs, but not as much in their back because their back is more straight up and down and the blood pooled to their legs. That's why we call it dependent lividity. Other ones for obvious signs of death, injuries incompatible with life is one that we see occasionally on exams. If we show up and we have a patient that has exposed brain matter or a complete decapitation is our prototypical example, there's no care we're going to do that would save that person's life. So we say injuries incompatible with life and we move on. That's a sign of obvious death. There's a few more. You can look them up in your book. Body temperature being cold is technically one of them, but it's one you have to be careful with. A cold person who's outside where it's cold, that's not an obvious sign of death. That's a sign that you need to rewarm the patient before you can pronounce them dead. But a cold patient in a warm room in a home and a cold core, not just cold extremities. We all know those people that have freezing cold hands. We're talking about you feel the chest or you feel the side of the neck is where I go a lot of the time. That is usually a very warm area, and if that's very cold, then we will occasionally use that as a sign of obvious death, and we won't attempt resuscitation. Other than that, that's what I have for this review session. Looks like we came out right around 2 hours again. I hope for those of you that are watching this that there was some beneficial stuff in there, whether or not you're going to be retaking this exam. And I wish you the best of luck on this exam. We'll have another, probably a big review session for the medical exam in a few weeks, because we just cover such a wide span of topics on that exam. So we'll see y'all soon.